Okay. So good evening, distinguished colleagues. I'm Dr. Irene Akidino, the Vice President and Chair of the Education Committee of the Intensive and Critical Care Society of Nigeria. Today, we'll be having the first of this year of our bi-monthly webinar series. And the topic today is Transport of the Critically Ill by Dr. Victor Raji. I will hand over to Mr. President to give Dr. Job Otokwala to give a brief opening remarks, and we can get the webinar going. Thank you very much. Dr. Jobson.
Good evening, very senior colleagues and colleagues. I want to welcome you to our series number 28. And we have one of our very best, Dr. Victor, who will talk to us on a very important topic. Most of us are involved in the transport of those who are critically ill. And this offers an opportunity for us to learn, unlearn, and equip ourselves to offer our patients the best. Thank you, Dr. Raji, for accepting to talk to us. Thank you, everyone, for spending this time and making the sacrifice to learn and unlearn. I know at the end of the day, we have every reason to be grateful. Thank you. I hand over to Dr. Irene to continue with the other parts of the distribution.
Thank you, Mr. President. So to get into the webinar proper, I would introduce the moderator for the session. He's Dr. Seun Oladokun, consultant anesthetist and intensivist at the Lagos State University Teaching Hospital. He's the head of the CCU at LASUT and also a guru in the transport of critically ill. It's nice to have you, Dr. Seun Oladokun, moderate this session. I'll hand over to you to start up with the preliminaries of the speaker and handle this next part of the webinar. Dr. Oladokun, over to you. Thank you.
Good evening, ladies and gentlemen. Thank you for having me on this platform. Yeah, as you said, I'm Dr. Oladokun. I work at LASUT, Lagos State University Teaching Hospital. I'm not the head of critical care unit. No. Thank you once again. Just wanted to make that correction. So let me quickly take the citation of the presenter, Dr. Victor Raji, somebody I know very well, one of us, as the president introduced him. Dr. Victor Raji is a consultant anesthetist and a pre-hospital care, critical care physician. He currently practices in United Kingdom. Is extensively experienced in medical retrieval, advanced airway management, critical care transfers, and he has a very strong focus on pre-hospital and system-based emergency care. He's a former senior flight physician with Flying Doctors Nigeria. He received the exemplary senior flight physician award, and he had previously served as a coordinator pre-hospital care school, contributing to national pre-hospital care training and capacity development. He is also CEO and chief flight physician of NMP Solutions and Rescues. He provides leadership in pre-hospital medical and critical care transport services. Dr. Raji holds multiple international certifications, including UK Airway Management, Strict Critical Care Transfer, ALS, UK, AHA, ACLS, and other. Hello, can you hear me, sir? Dr. Raji, can you hear me?
I lost you for like 45 seconds.
45, that's the entire citation.
Yeah, so I'm just hearing you now. I think I lost you when you say AHA.
Oh, okay. Oh, I'll quickly take that again then. So
Okay.
let me go back
No problem.
to. So, as said before, Dr. Raji is the CEO of and Chief Flight Physician of NMP Solutions and Rescue Limited. He provides leadership in pre-hospital, aeromedical, and critical care transport services. He holds multiple international certifications, including UK Airway Management. He has the Strict Critical Care Transfer certification, ALS, AHA, ACLS, as well as is also a prestigious winner of S.A. Oduton Faculty of Anesthesia Prize of the National Postgraduate Medical College. That was in 2016. He loves chess and is an international winner, and he has won several karaoke competitions. He brings strategic thinking, confidence, and he engages in anesthesia delivery as well as education. He's married with several children. So I welcome Dr. Victor Raji to the platform.
Thank you, my dear friend, Dr. Oladokun. Yeah, so I actually welcome everybody to this bi-monthly webinar, and I think we are in the series 28 of the Intensive and Critical Care Society of Nigeria, I-CCSN. Yeah, my name is Victor Ayanwale Raji, but you can call me Victor. And so we start the presentation without wasting so more time. Okay, so that is me. When I used to work with flying doctors, we were at executive jet transporting somebody. That's my late grandmother, lost her in August 2025. Right? She has been very instrumental into my progress, my graduation, me with B2s in Liverpool, Medivac of a patient, the award for exemplary senior flight physician. This is Charles Darwin in Shrewsbury, Okocha, while I was in Dubai, and this is our famous Lekki Bridge. And I'm dedicating this presentation to the loving memory of Dr. Musliu Odunola, which we lost. We lost him, unfortunately, and a plague when I was a treasurer. Okay, so we postpartum hemorrhaging. This is like a case Vignet in Nigerian context. So this is going to pose some provoking questions. Okay, so scenario is a 32-year-old Gravida 4 para 3 woman delivers vaginally in a private maternity center. So developed postpartum hemorrhage, which was within 15 minutes of delivery. So lost about 1.2 mils of blood pressure, hypotension, tachycardic, so signs of hemodynamic instability, hypovolemic shock, hemorrhagic shock. So the center has oxytocin available, but no tranexamic acid, no blood products, no anesthetist, no ambulance with monitoring, and decision made for transfer to tertiary hospital, which is 2 hours away. So the questions we are posing is, should we stabilize fully or initiate urgent transfer? Should we stay and play versus should we scoop and run? What should be done before transfer? When should transfer be initiated? What information must accompany the patient? What is the receiving hospital's responsibility? So you can see there's a lot of myriad of thoughts in our mind that I know we might not have all the answers to these questions, but we must actually interrogate this because it's more than our skill, our technical skills, but also our system thinking, organizational communication, and situational awareness and leadership. So objectives of this little talk is we define types of critical care transport, we outline modes of transport, discuss preparation and checklist, and then apply principles to common clinical scenarios. This is by no means a comprehensive dissertation or talk, but we will try to address the the heart of the matter, which matters. So we have several types of transfer, but we have two major types, which is more of intra-hospital transfer, IHT, or inter-hospital transfer, which I is coined as IAHT. So what are the types of transport? So we have non-urgent transport, which is elective, like escorts, urgent, which can be life-saving, and time-sensitive, which is actually real life-saving emergency. So what are the triage philosophy? Should we stay and play? That is, stabilize the before transfer. Should we scoop and run? So that is rapid transfer to definitive care. And so decision based on physiology of the patient, resources, and the distance. So for us to make a decision to stay and play, you look at the patient's physiology. Is it stable enough to be moved? Then if it's not, then we need to stabilize. If we need to move as fast as possible because of time critical transfer, then we need to scoop and run. But we need to scoop and run by doing what they call inline and ongoing stabilization during transfer. If you need to give blood during transfer. If you need to shock during transfer. If you need to do CPR, you do CPR during transfer. Let us know that transportation is not the cure. It's not the medicine that cure the patient. Transfer is not the cure, but we are just going towards the cure or the management. But we need to get a patient that's alive to arrive. Means of transport, it could be land, so ground, ambulance. So right here where we are, we must, according to guideline, it must be ALS equipped. And then we have mobile ICU ambulance, and then inter-hospital transfer vehicles. I am placing more emphasis on inter-hospital transfer in this presentation. Maybe another time we'll be able to talk in depth about intra-hospital transfer. So means of transportation, which is air, could be fixed wing, which is for long distance international travel. Like fixed wing means like a jet. So we have different type of jets. We have the Challenger, and we have the what they call layer jets, which have different distance they can travel, and space, accessibility, and different logistics. And then we have rotary wing, which is usually helicopter transfer, which is for rapid regional transfer. In the UK, we have the HEMS, which is more of a helicopter emergency medical service. And then full air ambulance services. Yeah. The other means of transporting critically ill patients, but usually more stable patients that does not need like time critical transportation, is to get the patients on what they call commercial stretcher service, which is actually booked on scheduled flights. This dissertation or presentation is not going to cover all the steps for all this, but just for us to be acquainted to different types of transport. So this requires medical escorts. So appropriate for stable but non-ambulance patients. So preparation. Before we move any critically ill patients, we must actually prepare. And part of the preparation is to do what they call pre-transport assessment. So you have to do what they call ABCDE reassessments. We need to hemodynamically optimize the patients. If we need to secure the airway, we secure. If you need to put the lines, we put the line, because most of these places are very, very, very space limited. You will not be able to do gymnastics while you are in the air, in a patient in the helicopter, because there's no space. Like, let me try to intubate a patient while being transported. Anything you want to do, you do it on the, what can I call it, at ground zero. Because of course, we know that altitude also affects oxygenation and stability of the patients. So we need to do everything at sea level as much as possible. We must prepare for adequate sedation and analgesia. Documentation and communication. Document the documentation and then make sure you communicate. Communication should be between the transferring hospital, the transferring team, the receiving hospital, and the receiving team, the transportation, logistics on the way, permits. Everything must be gotten. If the patient needs visa, health visa, the family that will go, clearance if they need to be cleared. It shouldn't be caught like maybe you transfer a patient without permit and then you are caught on the wrong way, which has happened to us in those days in South Africa. But we must actually we learn from that experience and we reflected and then we make it better. So communication is very paramount, and even the handing over from you document well and you have to hand over. We can use the S bar, which is called the situation, background, then the A for action and recommendations. Okay. So what are things we have to do before, the considerations before we transfer? You have to, in the airway, this is like a you have to prognosticate or predict what could happen, what could go wrong. So airway, if you see a critically ill patient that you need to maintain the airway or to provide some form of ventilatory function, and that is a concern, especially head injury patient, which might likely drop the GCS. So you must actually do some preventive pre-transport intubation. You don't wait while you are in transport and patient deteriorates before you secure the airway of that patient. So critically ill patient that you know that the airway might not be patent for long, or you might lose the airway, you should try to secure that airway. Breathing. Is that patient already having high ventilatory requirements like PEEP greater than 10, plateau pressure greater than 30 centimeter of FiO2 greater than 60? So recommendation is to use a transport ventilator, which you check, you know the capacity, and then it must have the capacity of the ICU ventilator before you move. So you must do a 30-minute trial with the portable equipment with some tubes for you to know that it's working. Then a patient has circulation being labile with labile blood pressure on ionotro. You should know that that patient is going to give you a lot of issues while you're being transported. When we get to the dynamics of transport, you will see what I mean. So minimally, most of these patients will need 2 intravenous access lines. So let me tell you that central line is not considered as a big wide bore access. So let us get that no, except maybe we use a Vascat, which we use for dialysis. So a standard central line will not give you the access you want. So we need those big lines like 16 gauge, even if you can get a 14 gauge, that's orange, 16 gauge that is gray, and you put cannula and you put them in the antecubital fossa veins. If you have the opportunity to use or expertise to use ultrasound, that will be very fine and be able to get.
Yes. Do you know anything?
And then identification of designated intravenous sites in case of cardiac arrest. Sometimes you might have to use intraosseous line, which we have some equipment that we can put it in the humeral head or the tibia tubercle. And then how to do it, you have to simulate it, you have to train people to be able to use those alternative access. And then you might have to dedicate a vein that nobody touches. There's a big that you have to, so pre-transfer transfer checklist. We according to International Critical Care Transport Association, a checklist must be an embedded cornerstone for a pre-transfer preparation. So you have to check the airway. Is it secured? You know the preventilator settings and they are documented. Breathing, oxygen supply adequate. So you have to do ×2 volume that you need, that you have calculated. We are going to talk about oxygen calculation later. Circulation, 2 wide bore access, as I said, and prepare the vasoactive infusions, and then you get them secured, and you check it on the checklist that is done. Check the disability of the patient. Some people use AVPU, which is alertness, verbal response, pain to pain, or comatose. So, but we have already even added C, so it should be no N. So A, that's alert. Then N is new confusion. So AN VPU. Because sometimes GCS Glasgow Common Score might be very cumbersome, but it's good to know because sometimes because we are transporting neurological patients or neurosurgical patients, GCS is actually more relevant. But if it is ALS or otherwise, AVPUs or ANVPU is very important to know. And then, of course, you have to know the new score also. So what is the exposure, temperature, any signs of bruising, abdominal distension, bleeding sites, and the rest, or rashes? We should be able to check those ones. Then equipment. Do you have multi-parameter monitors that can do SpO2, NIBP, that's non-invasive blood pressure, and then that can also do ECG, at least 3 lead ECG. And battery life of the equipment, they must be able to it must be adequate for the journey. Do you have the drugs, both emergency and drawn, and even the medication you need for sedation, induction, and analgesia, and of course emergency medications like atropine, glycopyrrolates, adrenaline, amiodarone, things for SVT adenosine, and the rest. And the suction is very important. So we usually have this checklist that we use those days, where we use this mnemonic called SOAP Me. S is for suction and suctioning apparatuses, and A for assistance, airway equipment, and adjuncts, and of course, O, oxygen, P, pharmaceutics, M, multi-parameter monitors, E, other equipment. So we need to have, that one can quickly make us to check our equipment and other things that we need. Not to waste time, what are the hazards of transportation? So we have the static hazards. So these hazards they are very obvious, and actually we'll be able to understand them, and they are actually readily appreciated. So this might include temperature, because if you go into if you fly, the temperature might be as low as -30, like 30 degrees. Noise can be a big hazard. Vibration, lack of space, poor visibility, of course, atmospheric pressure that will affect oxygenation, altitude, and the rest. Altitude, sorry, that and the rest. So they are very obvious, and there's a way we have to calculate and then bring them into the consideration. But the dynamic hazards are the ones that we cannot really appreciate, but they are very important. And they are usually in form of acceleration and deceleration. I think you remember Newton's third law of motion, which says that for every action that is an equal and opposite reaction. So if somebody moves and accelerates and they brake suddenly, then they decelerate, there will be an inertia, which is the equal and opposite reaction to that deceleration. This leads to a lot of movement in the body. You know, our body is made of fluid, cavities, which they have some, that's we call hollow spaces. They have hollow organs that can move from one part of the body to the other. Like classically, we have the counter-coup mechanism, which might accentuate and cause a secondary brain injury in a patient that's already having primary brain injury. So gravity is a form of acceleration. Um, so let's talk about the effects. Effects on cardiovascular system actually is that they reduce venous return. So can we remember the formula? Cardiac output is equal to stroke volume multiplied by heart rate. So when a patient is in the ambulance and they decelerate suddenly, it reduces venous return by pushing all the blood to the feet or to their legs. So that actually now reduces stroke volume, and actually then the cardiac output will reduce, and that can be very deleterious, very dangerous for a patient that is already hypotensive, that is on multiple inotropic and vasopressor pressure support. And we remember that mean arterial pressure is also a function of cardiac output and systemic venous resistance. So if the cardiac output is also reduced, the blood pressure will also fall. So that's why we have to be careful when we move a patient. So that means full patient travel better. What do you mean of full patient? You need to really fill up your patients by volume, give crystalloids, if possible colloids, and then make them to be adequately volume filled. We don't want to transport a patient that's volume depleted as much as possible. If they need blood products, and other things like cryoprecipitate, FFPs, even some other things, you need to give them for them to be full, even if they're losing blood. And then if they're losing fluid, you need to give them fluid because they travel better. So no matter what the dynamic will be, they'll be able to handle it better. Effect on respiratory system, the main thing is that if you look at the concept of ventilation perfusion mismatch, VQ mismatch, it is very, very evident because patients is lying supine. There's the dependent part of the lung, and then there will be an area that will be very well perfused and areas that will be well ventilated. This creates some form of physiological shunts, which can be accentuated by movements. Because blood will move from one part of the lungs to the other, stopping ventilation, to be aerated, some part of the lungs to be aerated, and maybe the good parts will not have ventilation, and then the bad parts will be the one being ventilated due to movement. So you can see the dynamics. For autonomic nervous system, we know that this acceleration, deceleration also affects the all those carotid sinuses, movements, so that and vasomotor center, which might lead to hypotension or even hypertension. So we have to be careful the way we move the patients. And the dynamic has that effect on central nervous system. So both acceleration and deceleration forces are potentially detrimental to a patient, especially if we do what they call hard braking. I think we know hard braking when we brake suddenly, maybe because somebody is running across our car, or somebody stopped suddenly in front of us, or an animal crossed the road, and then we need to stop suddenly. Some drivers actually do that because they overspeed and they have to stop suddenly. So sudden acceleration, sudden braking will cause raised intracranial pressure, which will be detrimental with a patient has already suffered intracerebral hemorrhage or intracranial events. So why sudden acceleration might even accentuate cerebral ischemia, because sudden acceleration pushes blood to the lower limbs and making the cerebral perfusion pressure to fall, and then leading to, so if the patient is already having some form of in ischemic stroke, there's this umbra penumbra concept. So the areas that are already penumbra that are dying, they will now suffer more ischemia, and then that can cause more brain tissue to be lost. So let us also talk about tipping of the patient head down while moving them up a ramp. That's number one. Or the patients, the way we position the patient in the aircraft that is taking off. When the aircraft is taking off, everybody's like head down in a way. So usually we put a patient that is having cerebral issues, especially maybe that's having that might have raised intracranial pressure, or they are predisposed to having raised intracranial pressure, for their head to be facing the deck. The deck is towards the pilot, while the haft, their leg will face the haft. If the patient is a stroke patient, we might do the opposite, okay, so that they have more blood supply to the brain. The head of the patient should be kept elevated to encourage cerebral venous drainage, because that can also cause a lot of issues. So effects on the gastrointestinal system. This movement also will lead to some gastric ischemia, or in fact, patient can have some motion sickness and they can vomit. So it's good to quickly put an NG tube before the patient is being flown, and which because of these reflux issues. And then head up is one of the ways we can combat that. So effects on trauma, patient can, when they have these long bone fractures, if you don't move the patient well, the deceleration can make the patients to have more pain. Pain can set up some vagovagal issues. The patient can have a cardiac arrest. So that's why we need to give them enough analgesia and actually immobilize, or what they call immobilize the fracture as much as possible. Either they put a POP, or if possible, bind them with some good bandages, so that there will not be sudden movement of those broken parts. As you know, a broken bone is a sharp knife that it can cut major vessels, and patient might die of sanguination and might not have blood while you are transporting the patient enough to combat that. So in summary, accelerative forces during transport may result in decreased cardiac output, hypotension, increased dead space, or increased shunts. So full patients travel better. So correct hypovolemia before setting off, correct hypotension before setting off, think about vasopressors on time, anticipate the need for increased FiO2, increase minute volume, and consider invasive ventilation early. So further, avoid acceleration where possible. Actually, ambulance and on hospital corridors when you are doing hospital intra-hospital transfer. Go slowly and steadily. Rarely do we need to use blue lights like police people, or we run along the corridor with a patient. So gently. Then let us consider the position of the patient in relation to the direction of travel. As I said, head, if patient is having some intracranial event, head should be towards the pilot because of taking up. And when you are, that means you can actually do head up when you are descending from the plane. It's easier to do that. Direction of travel, as you said, yeah. So some common conditions emergency conditions that you might need to medevac a patient. One of them is subarachnoid hemorrhage. So you have to secure the airway if the or you anticipate the GCS is going down or the GCS is going down. Control blood pressure. We must not have extreme of blood pressure, either hypotension or hypertension because of the cerebral perfusion pressure. We have to prevent the bleed as much as possible. Rapid transfer to neurological centers. No, we said we should try to be gentle as much as possible, but sometimes we have what they call time critical transfer for these patients. We can get to the nearest neurological center as soon as possible because they might do some endovascular therapy for that patient, like clot evacuation or stenting, clipping, depending on what, or like coiling of a subarachnoid hemorrhage, as the case may be. Okay, ischemic stroke is a time critical event whereby we might have to give thrombolysis or we have to do thrombectomy, as I said. So we have to maintain oxygenation to reduce cerebral injury, avoid hypotension, because I said about that areas which we call penumbra, which are dying areas in the brain after a major stroke, and then go directly to a stroke center in the well-resourced, high-resource countries, and and some areas that we have in the developing countries, because they have a lot of stroke centers now in our environment. Okay, myocardial infarction. So STEMI, so that's STA elevation myocardial infarction. So we need to transfer for a PCI as soon as possible. So within 2.5 hours, patient should get to a PCI. So that's what they call door to balloon time, which is one of the quality improvement projects being done, whereby from the time the pre-hospital people pick the patient up to when the patient is given like a balloon coronary intervention or stents to open up that coronary, block coronary, is being said it should not be more than 90 minutes. So, and we are allowed to do what they call ED bypass. So the patient will not pass through ED, they will go directly to the cath lab. So there will be a standing cath lab team that is also with an anesthetist that is embedded, especially if it's needed. And then, of course, cardiologist, interventional cardiologist, the nurses and the rest that will support. And then the patient will go there. We need to manage, so we have to do the continuous ECG monitoring. And they might, even this ECG might be transmitted on the ambulance directly to the hospital that's receiving the patient. So we have to manage arrhythmia because they can be arrhythmogenic. They might be in cardiogenic shock. So they might need some ionotropes, inotropic support, even some vasopressor support. And then we might have to give antiplatelet and then anticoagulation continuity. So they may have to continue with DAPT, that's dual antiplatelet therapy, or they may have to be given fondaparinol. They may have to be given something like heparin infusion, or even low molecular weight heparin, high doses, as per therapeutic dose, sorry, for them to continue. So that patient will need post procedural ICU, HDU, or CCU care. Okay, so you need to plan all those things. So for post cardiac arrest, you have to secure the airway and ventilation, because we have to do what they call post cardiac arrest or post cardiac arrest care, which is also embedded with TTM, which is targeted temperature management, if indicated. Literally, if a patient after ROSC, they don't regain consciousness, that's an indication for TTM. Okay, so you have to maintain the MAP greater than 65, even with the use of inotropic support. And because patients sometimes might have to be sedated for neuroprotection, so you may have to give some inotropic support or vasopressor support to maintain the MAP greater than 65. So, of course, there are some cardiac arrest centers that are springing up. the patient has to go to. Okay, so obstetric patients, maternal resuscitation is the priority. So sometimes people may neglect the mom and then they go for the baby. So, but maternal resuscitation is a priority. So put the patient on the left lateral tilt positioning to relieve pressure on the inferior vena cava for better venous return. We manage, and then of course, we also protect the baby from bradycardia or CTG abnormalities because placenta perfusion is also dependent on the venous return for the mother. So if it is hemorrhage, we have to manage hemorrhage. We have a protocol in my place. We do what they call major hemorrhage protocol, whereby if you call it out, you get a set number of blood product immediately. ONEG blood, like 4, you get 4 FFP and 2 platelets, or 1 immediately in a pack. They are already pre-packed for any abnormalities, any eventualities. So eclampsia, you need to like manage that. So transfer to the tertiary obstetric units as soon as possible. So medevac for trauma injury with chest trauma, with actually chest injury. ATLS principles, you might even need to do what they call finger thoracotomy, especially if patient is suspected to have pneumothorax. You don't need to really prove the patient has pneumothorax before you do the finger thoracotomy, because it might be life-saving. So after doing needle decompression, you quickly do a thoracotomy and put a chest tube. Actually, either you are suspecting pneumothorax or hemothorax or pneumothorax, mediastinum, mediastinum, all those combinations that might be very life-saving. Some patients might even have cardiac tamponade there, whereby you have to create a looser window and put a tube in the pericardiac reflection. Secure fractures and control hemorrhage and avoid hypoxia and hypotension, because that we can have the detrimental outcome for the patient. So we have a lot of UK guidelines and governance, which is CQC standard, I think Center for Quality Control, NHS Critical Care Transfer Guidance. We have a lot of guidance there that's well established, well audited, and well governed to take care of critically ill patients, especially their transportation, safe delivery, communication, leadership, training, retraining, and the rest. So international critical intensive care society and FICUM recommendations also there. Okay, so the other guidelines that are published relating to transfer of critically patients. So it is good for us to get. So I'm just leaving this the links here, so you go through them. They are very good resource for us to go through. So training courses that we can go: STAR, Thrive, Transfer Principles, Retrieve course for pediatric retrieval, Advanced Critical Care Transfer Training, and STRICT, which is for the Southwest UK intensive care or critical care transport, and many other ones that is being offered internationally. Even in Nigeria, we have a lot of courses for critical care transport. And if there's any time we need resources for us to organize some that will really go a long way to mitigate our issues in Nigeria, we are hoping to provide both training and support for that. Together and collaborate as the Intensive Care Society of Nigeria. Okay, so key take-home messages: 1, stabilize before you mobilize. Right patient, right timing, right destination. Preparation prevents deterioration. Communication is critical. So they are like raps. Okay, stabilize before mobilize, right patient, right timing, right destination, and so on and so forth. It's very important for us to remember all these Okay. Now, I'm not going to sound like a prophet of doom, but we need to, tie it home and see how we are doing in Nigeria and how we can reflect and improve. So we have some Nigeria-specific context in critical care transport that have, based on my experience, I might have to, if I have the liberty to talk about them, I don't want to ruffle any feather, and it's not a way of trying to indict or talk down on our system. Nigeria system, health system is one of the well developed in the world. We have our challenges, but we are actually working towards making things better. But we still need to talk about the issues. So we have limited neurosurgical and PCI centers. So early referral can be very critical. So if you have a patient that you suspect any neurosurgical issues or that might need some percutaneous coronary intervention, especially with a STEMI, you will need to quickly refer on time, because if you don't do it on time, you might not be able to get them to those limited centers. Variable road infrastructure and traffic delays. We know we don't pray. I know one of my family friends had to drive against the traffic in Lekki for up to he drove from Ikeja to Lutz one way to get his wife to the A&E in Lutz. And it was a success story at the end of the day, but the patient had like 3 cardiac arrests during that transfer. And she made it. Baby also made it. At the end of the day, when the woman was discharged back home, on her way back to deliver the baby, baby was delivered in the car. And that's why the mother did not come back to the hospital. So that is a clear and present danger for us because of the infrastructure is limited, especially for roads, and then there's a lot of traffic issues. We have limited air ambulance availability to position a jet. And remember, when I want to position a jet to take a patient on a medevac, it might take me up to 2-3 days. And we are talking about some time critical patient to be transported. And if they are not transported, they can't get that treatment in Nigeria. So it can be frustrating where you have to look at the patient's family and they know that you are trying your best, but things are not moving. So power supply and oxygen refill challenges, which I don't need to go there. Importance of stabilization before long distance transfer. We need to emphasize that, and the role of private-public collaboration in Medivac. Yeah, this is a very good way for us to come together, we and the government, private, and then we collaborate to establish some very strong Medivac establishments that will be favorable to the public. But we know that there are some challenges about payment. So oxygen calculation for transfer. So energy is equal to MC squared. Yes, according to Albert Einstein. But if you are full of energy and you want to move very fast in MC square and you don't plan well, it will be a big regret. So how do we make sure that we have enough oxygen? So we need to know the duration which the oxygen will last, and it's in minutes. So cylinder pressure minus safety residual multiplied by cylinder factor divided by flow rate. So we also use E-cylinder as the standard. So factor is 0.28. The residual pressure for an E-cylinder is actually 200 psi, pounds per square inch, and we know 100 kilopascal is equal to 14.8 psi, and that is 1 atmosphere. So with that we can calculate from the our gauge, oxygen gauge, to know what we are talking about. So when we get this in minutes, you will need to always multiply it by 2 for that journey. If the journey is going to last for 90 minutes, you must get the oxygen to last for 180 minutes. Because, of course, the ventilator will waste some of the oxygen, and there might be transportation delays. Actually, we are talking about traffic and the rest. I think time is really gone. So these are the things you have to do: prepare everything, backup, syringes, fluid, drugs. As I said, label them adequately. Always backup emergency drug. Get all the standard transfer infusions, noradrenaline, adrenaline, propofol, midazolam. Consider volumetric pump for high volume infusion, but we prefer syringe driver. Battery life that is greater than the journey time. Okay. Structural transfer algorithm. Identify need for higher level of care immediately. Is patient stable enough locally? Yes or no? What is the risk versus benefit of transfer? That is when you have to take consent from the family and from the patient and everything. Then choose appropriate mode of transport. Do you want land or air? What is your infrastructure? What are the philosophy and rest? Assemble a trained transfer team, not like somebody transfer for the first time that don't know most of the ethic. It can be very hectic actually. So you have to be physically fit because you have to be lifting heavy objects at sometimes. So and then you have to have a good cardio. So it's not only being technically sound, you have to be psychologically sound, physically sound, and also spiritually sound. Checklist. Always remember checklist. Is it completed? Have you communicated with the receiving center? Who is the receiving doctor? Is all the documentation done? Is the patient mobile, or they need some other things like on stretcher, or they have to be on wheelchair, or all those things. Okay, so we have to get all those ready. So I don't think we have time so much for this, but just like a scenario that we said in the front, in the beginning, we have some questions. So this is like the answer. So these are the questions. I think you remember this, a patient from Southwest Nigeria, 32-year-old with PPH. The hospital there does not have anesthetist, no blood bank, no transglycemic acid, no blood product, no ambulance with monitoring. Decision made for transfer to tertiary hospital 2 hours away, but only thing that's available was oxytocin. Please don't lose heart. Go at it. Try to stabilize that patient. Get 2 blood lines. Give fluid. Give blood products if you can. Some people can quickly do a spousal or somebody who need blood. They can transfuse, but if not possible, give oxytocin, give fluid, and then stabilize the patient. At least a patient that is well filled might be survive the journey. And then, so decision points. What should be done before transfer? When should transfer be initiated? Immediately, okay? So what should be done before transfer? You will need to plan, resuscitate the patient, do a good assessment, A, B, C, D, E, formulate a plan. So we have what they call STAR approach. Situation, task to be done, action is to actually assess the patient, stabilize the patient. What should we do to him? When should the transfer be initiated? Patient is well stabilized as much as possible, optimized hemodynamically, then we move. What information must accompany the patient case file, any other records, the ongoing checklist, and documentation intra transfer, and the name of the receiving or number of the receiving team. Yes. What is the receiving hospital's responsibilities? They must be ready to accept the patient and have the appropriate facility to take care of the patient. Not just because we want the money, bring the patient, don't worry. But they don't have everything on site. Okay. So even in low resource settings, you can do uterine massage, as we said. What can be done? As I said, IV access, rapid crystalline resuscitation, as I said, oxytocin infusion. If you can give transglycemic acid if it's available, clear referral notes should be done. Call receiving hospital before departure. Please call them. Delay in resuscitation before transfer increases mortality. And we find out that 64% of patients with PPH not well resuscitated die. They don't make it to the next, or they died soon after they reach the receiving hospital. So we need to, transport time alone is not is not only the thing that causes problem. It is actually lack of resuscitation before transfer. Okay, the golden nugget is transfer is not treatment. Stabilization must begin before movement. Okay, common pitfall in Nigeria inter-hospital transfer, delayed decision to refer, attempting prolonged management beyond facility capacity, fear of losing revenue, hierarchy delaying escalation. We must talk to the CMD. We must talk to this person. We must talk to, it can cause a lot of delays. Result, patient deteriorates before movement. Okay, inadequate stabilization before transfer, no IV access, no fluid started, no airway secured, no hemorrhage control, patient arrives in peri-arrest state. No pre-transfer communication, receiving hospital unaware, no bed secured, no theater alert, no blood prepared, causes further delay on arrival. So those are the Ds that can lead to deaths, delays. Poor documentation, another D. No drug at chart, no timing of events, no estimated blood loss, no referral summary, really leads to clinical errors, medical legal risk, poor audit data. We know nowadays our patients are looking for, they have a lot of lawyers looking for malpractice. So we need to really cover ourselves. Inappropriate transport, no monitoring, no oxygen, no train escort, no resuscitation equipment, transfer before it becomes a high-risk event. But financial barriers, family are asked to deposit funds before referral, delay in ambulance release, delay in blood procurement. This is a major contextual reality in many Nigerian settings. And this is what we should do, and we should be part of the advocates to change the narrative for a better transport and pre-hospital care. We can have the best state-of-the-art hospital as they are springing up all over Nigeria, but pre-hospital care is a very major linchpin and chain, link in the chain for survival of many of our teeming population. So, in conclusion, in Nigeria, many maternal deaths occur during or shortly after transfer, not because of distance, but because of systems failure. So we must think systemic change, systems thinking must be part of the thing. We'll be going leadership, communication, QI, governance, guidelines, education, training, retraining. Drop what we need. Let me tell you something. Low resource settings does not equate to low resuscitation setting. You don't say, we are low resource. We don't use this machine. We don't. But we need to have the knowledge and the way, with that, to be able to stabilize our patients, no matter how low resource we are. I know this is better said than done, but I think coming together as all of us, we can be able to do something for our teeming population that actually needs us. We don't want snake evaluation to kill our people again. We don't want lack of basic ABC to E assessment to kill our patient. Just to put lines and sustain the patient will go a long way and communicate better. So these are the further readings. It goes a long way. In fact, there's one that says critical care safe transfer training. That resource is PDF is a must read. We must read it, and I know we're gonna do that. Thank you for your attention. 12 different languages saying thank you. Gracias, merci, obrigado, danke, eshongo. Thank you very much. Dalu. Nagode.
Wow, Dr. Raji, that was an extensive talk on critically from, that's what you get from a guru in the field. Thank you very much for all those beautiful words and your terminating words to encourage us all. Thank you very much for that. So we go to the questions and then answer. We have one of our people online asking, in an unplanned situation, how do we go about intubating the patient during the transfer? Would you like to take the answer?
Yes. My short answer to that is that don't let it be unplanned. Does that make sense? It should never be unplanned. You must be able to assess your patient and identify the patient that we might potentially need to be intubated. And the indications are very clear, usually. By the time you do a very thorough ABCDE, you know that this patient will most likely need intubation. So, but if it is unplanned, at the end of the day, no, life happens. So you need to, if you are in the ambulance, no space, you need to stop the ambulance, get the patient out of the ambulance, put them on the tarmac. If I say tarmac, might be on the road, side of the road, but safe. Be safe. Not on where there's everybody, the car are moving like high speed. You can't put anybody there. So you have to be safe. So, but that is the option you can have to put the patient on the floor and intubate the patient and put the patient back in the ambulance and zoom off. Sometimes you might need to go out of the road and go to the nearest hospital or facility. I think something like that happened to me somewhere in the Middle East. Uh, I don't know, there was a battery failure of our ventilator. And that was and we had the backup and we had the battery and everything. But that day, it was destined that nothing will work. There was a big what they call review of that incident. So I had to tell the ambulance driver to go to the next hospital. So we got there, and then they gave us their own 2 transport ventilators with good batteries, and then we left. So what we now discovered later was that the model that was there was an expiring date for those models. And the technical guys actually missed it. They didn't give us that information. So many of them had to be relieved of their duties. And I don't know, yours truly was actually commended for thinking fast to move the patient to the nearest hospital. So if that is the situation you face, that might be the saving grace. But if you are on the helicopter, you don't have any space. So you tell the pilot to land in the nearest clear field. So there are a lot of primary schools. In fact, sometimes on the road, they will land and then you'll be able to bring the patient out and intubate. But you know that you can do some rescue ventilation as soon when you can before you can get somewhere to put that patient. So we are thinking about a mission MI6, that's Mission Impossible 6 kind of thing, like Tom Cruise kind of action. But it can be done, but it's better to be safe than being a James Bond or John Wick. Okay.
Well done, very much. Thank you very much for that response. Yes. So we have another comment on the type of monitoring that is required when transferring patients. What is the minimum you would suggest that we prep when we are taking these patients? And
So,
if possible, you can break it into inter and intra-hospital transfers. What we need when we're going outside of the facility and what we need when we are within, going to radiology, for example, or going from ICU to another unit. So if you can make that brief. Thank you.
yeah, I will try. So thank you very much, Dr. Oladokun. That's very, very good questions. And thank you for the person that's asking that question. Okay, so I think the first question was, can you remind me again, please?
The type of monitoring we require.
Okay, so
when transferring patients.
Okay, so there is this AAGBI, Association of Anesthetics of Great Britain and Ireland, standard monitoring, which is more basic monitoring, non-invasive blood pressure, pulse oximetry, and 3-lead ECG. Those are the basic monitoring you must have, the 3 of them. But if you don't have, if you don't have anything, you must have a pulse oximeter. So if you don't have an ECG and you don't have because of resource issues and you don't have non-invasive blood pressure, you must have a pulse oximeter to the minimum. So it's good to buy this finger, but it must be CEI approved for health as much as possible. Because sometimes when I get some like 15,000, 5,000, might not be very good quality. So you might have to have those very good ones. But there was a time when I was still in Luth, they are doing this, I think they call life box. So those kind of pulse oximeter are very robust and good. Some even have this combination of they can even still do blood pressure and then they can do ECG and then they can also do, but they are portable and then they can do pulse oximetry. So for intra-hospital, inter-hospital, they are basically the same thing. The only thing is the distance is different, okay? And but you still need to calculate the oxygen that you need to take the patient to place like interventional radiology, cath lab, MRI, especially MRI. That you might have to stay there for like more than sometimes 1.5 hours. It might even be like a minor transfer from between one town to the other. So we call that one inter-facility transfers. So facility like ICU to MRI suites. So you will do a checklist. So you can use SOAP me if you cannot remember all those BBI falloting things. SOAP me means skilled assistant that is trained to assist. And you also have, you should have, it's for oxygen and oxygen delivery apparatuses. Airway adjuncts and airway equipments. I don't want to break them down, but airway, oxygen cylinder that you have already calculated, suction for S is also for suction that's working. You can have a portable suction or the one that's at the wall, and you should also have pharmaceutics. Pharmaceutics means drugs, so emergency medications and the non-emergency medications. You must have all of them. And then monitors, as we said, the multi-parameter monitors. It should be multi-parameter, and then other equipments that you might need. Okay, so you must have a bag. Usually we have these grab bags, and then you must check these grab bags every time. You must carry the grab bag. Yeah.
I was listening for is the aspect of ethics. How do we go about consent, discussing with these relatives, looking at success during transfer or completing this transfer? We know things can happen when moving critically ill patients. How do we navigate these waters when it comes to this?
Actually, Dr. Oladokun, that's a very big topic. Okay, this presentation is by no means enough to go into that. But in summary, you must take consent before you do anything, unless you'll be said you have done abduction or you have done battery or assault. So the consent is lying in the same thing, but now you are actually going to transport a critically ill patient. So there's high chance if it is critically ill, okay, because we have other transportation that is not really time specific, but there's some things that there's high chance of a patient dying during that procedure. So you need to actually sit the family down. They are not going to give consent, but you need to inform them. At least in our jurisdiction, they don't give consent. It's the patient that actually gives consent in our jurisdiction here. But you need to sit them down, carry them along, tell them all the nitty-gritty, and then is it in the best interest of the patient? Is the intervention readily available within your facility that you don't need to transfer the patient out? If you need to transfer the patient to where they're going to have that intervention, what are the hazards on the road? Is it going to be what appropriate? You have to find out the appropriateness, because some patients have what they call respect form, or what they call advanced directive or a living will, that they don't want all these let me use that word, shenanigans. They just don't want resuscitation. They don't want intubation. They don't want. You need to check for that patient respect, or what they call escalation treatment escalation plan (TEP). So if you have all those information, you need to now speak to them. It's not like if it is, but if they said, okay, yeah, the risk, the benefits outweighs the risk, then that talk and get consent and move the patient. But we have to talk about cardiac arrest, CPR, and where patients might be recovered. Patient might actually not get to might not get to that intervention, but um, so they might not get to that intervention. But even when they get to the intervention, in that facility, they might end up being in the ICU, and end of the day eventually die. So those are the so ethics. You have to maintain confidentiality, you have to maintain dignity, privacy, and of course clinical and information governance, data protection. Make sure the patient is as you have sometimes if you want to transfer the patient will be on the tarmac to go onto into the aeroplane. Patient is in the open air, so you need to maintain that dignity, maintain privacy as much as possible, use of screens. Sometimes when you are in the commercial stretcher, we are going to buy up to like 8 seats or 9 seats or 10 seats for them to be transported on that commercial. You should try to protect their identity as much as possible, their privacy and dignity. And then there's no need to transport a patient that is for like maybe just for palliation and advanced cancer with mets everywhere, liver, brain, and then the life expectancy. And again, what is the function of the patient, functional activity of the patient before that problem? Are they bed bound? Are they wheelchair bound? Are they independent or dependent? So, what is their activity of daily living? What is their Kali or DALI? That's disability adjusted life years, or their quality adjusted life years. If the DALI is higher than the Kali, you don't need to. So you need to speak about everything and then make the final decision is a medical decision. It's not like family will say, yeah, this and that, but you need to let them know the outcome. So medical legal
Thank you very much.
angle is very important, because if you don't do that, you might be on a slippery banana, and then all your efforts, even though you want to do the best, patient's perception is very important.
Thank you very much, Dr. Raji, for that beautiful presentation and the response that you've given us today. And I would have loved to talk about positioning, comparing land and air ambulances, which direction we should face the patient. And of course, somebody in the group has already mentioned that our drivers on land ambulance need to have additional training, because they tend to accelerate and decelerate. So those are things that we face down here sometimes. We need to train our drivers, train ourselves. And now, so one question before we go. Do you think every critically ill patient should be accompanied by a physician? Or you think a paramedic can handle everything when well trained? So
Okay.
Yeah.
Okay. This is a topical issue. Okay. That's why we have to do what they call triage. So the answer is no. Actually, it's no. Yeah, we have a lot of well-trained paramedics that do a lot of pre-hospital procedures, and they know their salts. Like this, what they call LAS, Lagos Ambulance, I say Lagos, London Ambulance Service. Of course, we have this Lasambos also. They are very trained, but there is this last. In fact, if you see, most of them are being manned by paramedics, and some are nurses. Nurses actually, there are some transport nurses that are well trained within the facility, that are embedded within a team. So there is discussion between uh, having a dedicated transport team in a region, in the hospital, vis-a-vis you in the hospital being trained to be able to handle your transfers. So they've said that advantage of having retrieval team that have everybody. So in fact, the way they organize them is that we have paramedics, nurses, doctors, physiotherapists, and a consultant that is the lead for that. So we have what they call retrieve group. We have what they call strict, like the strict training I did. And then we have when there's one more thing I forgot about the name they call them. So, but the thing is that if we have all this group that have everybody, your own staff might lose their skill in being able to transport patients. So that is the topical issue in the UK now. So now we are placing more emphasis in training our own staff, and you find yourself sometimes in the middle of nowhere transporting a patient. I remember one day I was going for 2 hours duty, and I ended up transferring a patient, and I came back 8 hours later. Though I was paid for that, but you have to be ready. Because they know I was trained to transfer in that context. So, and also you need to trial the patients to know their level of acuity. You also might determine, and then sometimes it's not your training that is important. If I say training, as per your cadre, it is your experience. There's a lot of nurses, paramedics that are very experienced in transportation. And me as a consultant, I can't compete with them. Like, as me, I don't have my own training as like a critical transport person. I might not be able to compete with them because they have experience. Yes, for some of them, I've been working there for like 20 years. So I can't just come one day and say I know it all. So I'll just be team player. So team playing, very important.
Thank you very much, Dr. Raji, for
So
that.
good. There's somebody
Dr.
listening
Jacob,
up around. Yeah, Jacob.
Dr. Jacob, you have your hand up. Would you like to speak?
Okay, yes, I want to speak. Thank you, sir. Thank you for your presentation. And I don't know. I want to speak from the current situation. I'm currently the head of our state emergency medical service and ambulance systems. So I want to ask a question based on the current situation we have at hand.
What
There
state is
are
that? Sorry, if you can share.
Akwa Ibom State.
Oh, yeah, that's yeah. Nice to meet you, sir. Yeah.
Okay. Okay, so there is this patient I have that they've contacted me for a transportation from Akwa Ibom State to Lagos. And the patient is actually oxygen dependent, fully conscious, being managed for congestive heart failure. Everything, we have an ICU ambulance that we can transport the patient, but the challenge is the bad road. And it is not possible, no matter the number of cylinders that we are going to put in the ambulance, for us to transport that patient from Uyo to Lagos State at a stretch. We have a challenge of requiring to do a fill up as we go on the way, or we may have to branch a certain hospital to stabilize the patient or continue oxygen support before we continue the journey. My question: the consent that we are going to take in Uyo, and peradventure the patient needs to be managed, stabilized in any other hospital along the way, does that consent covers it? That is my question. So the problem we are having in Nigeria currently is really we cannot predict our transportation. Most of the ambulances, because of NEMSAS, are being monitored with speed limit and GPS tracked. So we can monitor the movement of the ambulance and control the drivers based on the transportation guidelines that we have been trained, especially for me as a consultant anesthetist. But the challenge is the bad road makes it difficult for you to have the availability of for you to estimate what you need to use on the patient. So I want you to kindly assist in that response in that manner. Thank you, sir.
Thank you, Dr. Good. Yeah, that's a very beautiful name. Nice to meet you. Okay, so just a very fast response. Yeah, the consent you take from the transferring hospital covers all true. The thing is that there must be adequate handover. That is by SBAR from one team to the other. If the same team is not going to transport the patient to the final destination, not the mortuary, actually, as per the receiving hospital. So, and if we do it internationally sometimes. In fact, sometimes there was a time I was transporting a patient to China, Guangzhou, and then we have to stop at Istanbul, and then the patient is not stable enough to be within the ambulance, at air ambulance. So I took him with land ambulance to the next hospital facility near the airport. And then the patient was there. We embedded for 3 days. Patient stabilized, and then we started moving the patient again. So you're allowed, but that consent subsists, okay? But there must be handover. Even in that hospital, I didn't do anything. I just handed over to them. They continued the care, and I came to retrieve the patients again. So I even went to do some tourism, okay? But focused tourism. So yeah. And then node network. Sometimes you might have to like speak and plan it well. If it's amenable and they have enough resources to transport the patient by helicopter or by fixed air ambulance, local transfer, it is possible to move that patient that means. But if, as you said, we have sometimes because of resource poor issues and finances, patient has to pay out of their pocket, family have to pay out of their pocket. They may have to go through the like air ambulance. The land ambulance. Even the land ambulance is not cheap, and the road network is also a challenge. So it is it's a yeah, but we just know have to be pragmatic and plan along team communication, teamwork, good leadership, governance, as you said, command and control, as you said, from the command center, monitoring, quality improvement, training and retraining. So we can also put that as part of curriculum to teach our drivers how to move along portals. I think maybe in a driving test, they should put that part of the curriculum. How to move a patient safely, well, even though you are within the bad roads. So yeah, different terrain. I think that would be a good way of also managing things according to our own local realities. I saw a question about heights to maintain why in the ambulance. Actually, we're always talking about 3,000 to 30,000 feet above sea level. But nowadays, because most of the planes are pressurized, it has stopped to be a very big issue because they are pressurized. So you'll be as if you are at the sea level with that. It's just that sometimes when you are ascending, and then there might be some small issues, but most of the cabins are now pressurized.
Thank you very much, Dr. Raji. And that takes us to the final discussion. We know very well that air bubbles can be a problem when going up, That's why oftentimes we try to clear all the tubings, make sure our bags is collapsible types, We try to make sure the patient has had any invasive procedure that may leave gases or anything under the skin or in the body several days before allowing time to do that. Do you want to comment on that before we go?
Yeah, Boy's law, it also comes into play. These are physics, normal physics things, Boy's law, Charles law, Gray-Lussac's law, all those things. But I think it's Boy's law that is more. So volume is inversely proportional to pressure or something. Sometimes I confuse them. So the smaller the lower the pressure, the higher the volume. Okay. So that means if there's any small air pockets anywhere, even your endotracheal tube, it will expand when the plane gets to some certain heights. And that might be a very bad thing, especially maybe it's a cough. It will lead to a lot of necrosis, even trachea tear and perforation. And of course, much more very important is if there's air residue in the somewhere in the mediastinum or in the pleura, it can lead to actually lead to a tension pneumothorax. And then we'll now be talking about the reversible T's, tension pneumothorax, and patient may enter into cardiac arrest. So if a patient should suffer a chest trauma, it is always very advisable to put a chest drain, a chest tube. Either you do the big one, surgical chest tube, or do finger thoracotomy and put a tube, or you put a pigtail, and then before that patient is being moved. The endotracheal tube, you might use saline as the means, not air, for that endotracheal tube. So we always advise to put saline as the thing to use to inflate the endotracheal tube. Some people use helium, because helium does not expand. But I will not. We don't usually have helium, so we just use, because it's an inert gas, or argon. But we can use. I'm not very sure, but I think so. Saline is just the safe. Yeah. Hope I've addressed that issue.
Yes, of course, very much clearly. Thank you very much. We have Dr. Ayanwale. Would you like to unmute yourself and ask your questions or make your comment?
Dr. Raji, thank you very much.
Stephen,
My boss, thank you very much for your detailed presentation. I run emergency ambulance services in Lagos. And for the purpose of this presentation, I want to just say one or two things that you have said about preparation is very, very important. I have a story where I reviewed a patient that's supposed to go to Delta State, and it's a cardiac. There was a cardiac patient. So I had what could happen for a patient who had been in the hospital for about a month, and because she was better, she needed to be moved back to her state. So because of the cost inflation, I told them a doctor must be on board, because I was already thinking of pulmonary embolism or whatever. So, but they refused. The doctor said, no, my mom is better. My mom is this. My mom is okay. Is it not the one walking up and down? So I say, if you don't want, you have to sign. So they signed agreement that you don't want a doctor, they are fine. Lo and behold, on the way, the woman said she wanted to ease herself and put it like that. So she came out of the ambulance by the roadside. She eased herself. As she was going back to the vehicle, into the ambulance, as she was about to lie on her bed, she just went off. So we rushed her to, that happens around Shagamu, Babcock area. So we rushed to Babcock Center. But before then, people started calling from everywhere. America, Britain, everywhere. Because she was a very, in quotes, very important person. Now, what I want to bring out in this story was that what state was that documentation? Even the hospital that called us, just told them that we engage professional ambulance service provider, and we just gave them the letter that they signed that they don't want a medical doctor on board at all. And of course, the prayer went down naturally. If not for that letter, they would have accused us of using incompetent people or whatever. That's one story I want to say. The second one was the issue of anticipating what you cannot predict. If you are taking a patient from Lagos to East, for instance, you should consider spending about 5 hours either in Benin, bypass, or somewhere. And at times, we load our ambulance as if we are selling oxygen. We don't know what could happen. Despite that, the oxygen can still get exhausted. And it happened once, and we learned a lesson. So the lesson we learned was that now from Lagos to the East, we decided to approach different ICU centers. For example, if you are leaving Lagos, if you have any issue between Lagos and Redeem, we know that Redeem, they have standard ICU center. From that place to Babcock, we have an agreement with them. From Babcock to somewhere in Benin, we have an agreement with them. So to Asaba, we have an agreement with them. Because what happened to us the other time was that we could not see any facility to admit patient. All of them, they will look at the patient and no, this is beyond us. Oh, this is beyond us. So since that incident happened and we could not get a particular place to admit patient, so what we did since that time was that we had arrangement, written arrangement with different ICU centers along our route. And most of the time when we are taking off, we alert them that we are engaging, on this journey, and in case there's any issue, we would like to contact them. So that's just my continuation, my contribution when we are talking of preparedness. So once again,
Thank you
thank you very much, sir. Yes, sir.
Thank you, Dr. Ayanwale, for for sharing that experience with us. I'm just asking, is it possible, should we consider refusing care when we think the patient is asking for too much, or patient is going to be at risk if we engage them as they want? So is it something that we should consider? Just don't do it, or just send the patient to another person. It's just my thinking. Professor Uwaso, welcome. You have the floor, please.
Thank you so much. Thank you, moderator, for having me. I want to just thank our speaker, Dr. Raji, for doing very good justice to this topic and for sharing his clinical insights. And I also thank the last contributor, Dr. Akaramale, for that insights that he has shared. I want to just, add to what has been said by saying that we need to continue to emphasize all of the things that have been said by the speaker. We need to, make it like a continuous process to always teach about these things on regular basis, because transport of the critically ill is something that is so important and so dicey. I personally have been involved as somebody transporting my own a relative, and I just want to say that no matter how much prepared you are, you still have to know that anything can go wrong at any time, and it can go wrong when you least expect it. The thing about Murphy's law now comes to question. So as much as we are preparing and we have everything that we need, let's have what we need, even more than, if we need it like double, let's prepare for 3 or more of that equipment, or like, let's say, like oxygen or whatever it is that we are thinking that we are preparing. And let's also know that you can never be over prepared. You can never be over prepared. So that's just what I want to say. Thank you so much. Thank you so much, Dr. Raji. It has been an excellent presentation, and thanks everybody.
Thank
Bye.
you, Prof. Yes.
Thank you very much,
Thank you
Ma,
for
for
having
that.
me.
Yeah, thanks a lot. So we go to our host to give the vote of thanks, and I will sign out from here. Thank you very much, everyone.
Thank you very much, Dr. Oladokun. Thank you very much, Dr. Raji, for the wonderful presentation. I'm Dr. Ojedoyin. I'm the PRO of the Intensive and Critical Care Society of Nigeria. On behalf of the President, Dr. Job Otokola, the Executive Officer, and all the members, I want to especially appreciate you for your time, your efforts, and your contribution. It has been a very wonderful time for learning. A lot of things has been said that I know that many of us need to go and review some things and also to lay emphasis on more other things while transporting critically ill patients. We appreciate you for this. Dr. Oladokun, we thank you for taking up the moderator's position. We really appreciate you. And we hope that anytime we call on you, both Dr. Raji and Dr. Oladokun, you will be handy to assist us more with this wonderful topic and more. Thank you very much. I also want to appreciate everybody that has been around for this webinar. It has actually been a very fantastic day. I can see a point where we are having over 200 participants in this webinar. I want to appreciate us, and I believe that we've learned one or two things that can help our practice. Thank you very much once again. I hand over back to Dr. Irene, the chair of the academic committee. Thank you.
Prof. Konje. Prof. I really appreciate them. Yeah.
Thank you very much. I would hand over to Mr. President to give the closing remarks. Just to say our conference in Abuja is coming up, but I'll hand over to Mr. President to give the closing remarks and end this.
Thank you very much, Dr. Victor. Victor, it's like you've been running away from us a long time. We've heard from you. And then we are lucky today to have you. We see how much you've impacted in our learning process by all that you've said. Thank you very much. We hope that you continue to make yourself available to us so that we can tap from this vast knowledge that you have. You are a practitioner, you know what you're doing, and that's why it's much easier for you to talk to us in the way you did. And there's something you said, when you talk about the intra-hospital transfer, and you said, maybe if you go into that now, maybe you will not live here now. So it makes a lot of sense to us that you have enough to share with us. Please, always make yourself available. You are doing much more than this. I know you're chasing money to an extent and knowledge as well. So make yourself available to us. The society needs you. Everybody needs you. And one take-home point I think I want to emphasize is that all of us should go home at the end of this meeting to generate checklists for the transfer of the critically ill patients, either for A&E or for OR or even the ICU as well. We should go home and generate so that when we will learn, and then we'll learn and then unlearn and make progress in our practices. I want to especially appreciate the moderator and very senior colleagues who actually, logged in. I could see Professor Fakponle, Professor Disalu, Professor Elizabeth, and our immediate past president, Professor Bibio Shinake, many other very senior colleagues, and our friends in emergency medicine and other parts of medical practice. Thank you very much. Thank you, everyone. We are grateful. We know that we have a lot to share in subsequent series that we shall discuss with everyone. So we know that you also make yourself available in subsequent webinar that we shall have. We're trying to tap into the diaspora, see those who are practicing this aspect of medicine that we really need in our practice. And I will encourage us to do much better for our patients. Thank you, everyone. Thank you, Dr. Irene. You can wrap up.
Thank you very much. It's been almost 2 hours well spent. On the screen, we have our flyer for our annual conference, which we'll be holding in Abuja in July, 6th to the 9th of July, 8th to the 9th of July. The theme, Sustainable Financing for ICUs in Public Health Facilities, Challenges, Opportunities, and Solutions. There's also a call for abstract. Deadline is 12th of May. The conference is also there. This is on our website. Our website is has been posted on the chat box. Intensive and Critical Care Society of Nigeria. If you just Google that to get to our website, you would see also the recording of this webinar there and be part of our conference. We hope to see you at our next webinar, which will be duly circulated. Thank you very much. Enjoy the rest of your evening, and God bless us all.